Hello, my name is Dr. Noval Zackarya. I'm a gastroenterologist. Some of the danger signs could be that the child is listless, that he can't stop crying, and that they're unable to drink too many fluids. And bear in mind that the amount of fluid that they're losing is very difficult for children to catch up and have that orally, sometimes because the diarrhea could be 3 to 6 episodes in 24 to 48 hours, even if if it's associated with vomiting, that could be quite a huge fluid loss.
What are some common gastrointestinal symptoms that children may experience, and when should parents seek medical attention?
The common symptoms that children can suffer from, usually it's a wide spectrum of them. We can start simply off by the patient can have vomiting, abdominal pain, diarrhea, there could be fever, and all of these symptoms themselves can result in low energy levels in which we describe as lethargy. And a chronic manifestation of these can be a failure to thrive. And that basically means that children are not able to catch up with their weight as much, catch up to their energy level. There might be a deficit in height. And the best way to show that is that there's comparison with their siblings. So a failure to thrive is something that happens when there's a chronic illness going on, and that needs investigation. So out of all of these symptoms, diarrhea is one of the most notorious ones on our side of the globe. Usually in the world, there are around 3 billion cases annually of diarrhea at least. In our side, with a population of 225 million plus, diarrhea is something that commonly occurs in children, and it's a 60% cause of death in children. And even though the mortality rate even though the infant rate in our population is just 15% out of the total, the mortality rate by diarrhea in this infant population goes up to 50%. So that's quite high. There are a lot of factors that can contribute to diarrhea, and mainly that is that there could be poor sanitation of water, there could be unpasteurized liquids, fluids, milk, and there could be cross-contamination simply from just grabbing it from different surfaces. And there is an issue of overcrowding in our setup. So definitely these are one of the more notorious things that are reversible if you get proper education, if you give proper programs, and parents can learn about these things. But obviously there are some limitations. Now, if you talk about gastroenteritis, this is commonly referred to as a stomach flu. There are many agents that can cause the stomach flu, and this is just a term that most parents and the public likes using to describe what this huge spectrum of clinical disorders that their children might suffer from. And this can even happen in adults, but mainly if we're talking about children, the common symptoms would be that they could develop vomiting, they could develop abdominal pain, they could develop diarrhea, there could be a persistent fever and a loss of appetite, and the common agents are viral, bacterial, and parasitic. Common ones being the rotavirus, Campylobacter, Shigella, Salmonella that also causes typhoid, and E. coli, which basically causes traveler's diarrhea. These are some of the more notorious viruses that are commonly present. Vibrio cholera that causes cholera itself is also quite a dangerous bacteria. So moving forward, how do parents know that this is a good time to take their children for a checkup? Or what are the danger signs that they should be looking for? So aside from the symptoms that I've mentioned, some of the danger signs could be that the child is listless, that he can't stop crying, and that they're unable to drink too many fluids. And bear in mind that the amount of fluid that they're losing is very difficult for children to catch up and have that orally, sometimes because the diarrhea could be 3 to 6 episodes in 24 to 48 hours, even if if it's associated with vomiting, that could be quite a huge fluid loss. When they start crying, they might not have tears because of the dehydration. Eyes appear to be quite sunken, and urine output is quite low. So this is something that parents might notice, and overall the patient's quite lethargic. That might warrant them to come and see a clinician immediately. Now, once they bring the child in, after a simple general physical examination and after taking the history, most cases it's quite evident how the patient needs to be treated. Most of the time, just an oral rehydration solution is enough for the child to maintain back his volume and his energy. And antibiotics are usually indicated for diarrhea which is associated with fever, for diarrhea which is associated with blood in the stool, and if there is persistent abdominal pain. So in most cases, that is something that gets prescribed. Again, another notorious issue is that maybe sometimes there's overprescription of antibiotics. So this is something that education programs need to be conducted, awareness programs need to be conducted, patients, parents need to be educated, children's parents need to be educated. So we need to start off from step one, which is, how is it preventable? So in order to prevent something as common in gastroenteritis, simply would be to make sure that you have filtered water available, which is not easy for most patients in our side. Another thing is to make sure that there is overall sanitation, at least in the household, because this transmission of most of these bugs that I had mentioned is fecal oral. So that basically means that there is, if a kid has diarrhea, then if there's cross-contamination of the fecal matter in any of the area because of poor wiping, sanitation, and cleaning, those surfaces are contaminated. Children who are in overcrowded areas, or whether they're in nurseries, or even if they're in a hostel actually, this cross-contamination occurs from touching surfaces. It can occur from unfiltered water and contaminated water, and also it can occur from unpasteurized milk, which basically, and what is pasteurization? It's basically just heating up a liquid into around less than 100 degrees just to make sure that it kills off most of the pathogens. Again, with fresh milk that might be a bit of a problem, and that is what's readily available in most areas. So this is a multifaceted issue that can easily be preventable, but certain steps can only be taken by the families, and certain steps need to be taken at a much higher level by the governing state in order to help people and prevent this mortality rate from happening. It'll be a while before we see a significant decline, but I think what we need to do is create more public awareness and to just manage to get our word through to the public. Moving forward, there are obviously other causes of diarrhea, such as gluten sensitivity, which we call celiac disease, and there's also lactose intolerance, which is basically a type of carbohydrate that some children might have difficulty in digesting. Abdominal pain itself is a symptom that might be associated with gastroenteritis, but it might be a separate entity of its own, and that might happen in, again, celiac. It could even happen in children that basically have acid peptic disease, and that is basically inflammation of the stomach lining, and that too can predominantly occur because of an infection. Abdominal pain, it could happen from point A to Z. This could be a manifestation of chronic constipation, so that could be from lack of fiber intake in the diet. Abdominal pain, again, it can happen because of cramping from diarrhea and dehydration, and this is also a part of the functional GI disorders that can occur in, for example, more commonly adolescents, which I'll get into. In terms of moving forward, if we talk about all of these symptoms, they kind of overlap in most cases, and in other cases they individually need to be checked into. Now, if you have a patient who's having diarrhea which is associated with blood, keep in mind that and this is just one clinical entity, the duration for us really matters. Now, if you have anybody with an acute illness, then that can be recovered that is just temporary, and after medications, oral rehydration solutions, even IV medication fluids, the patient might improve. But if you have diarrhea, example, which is persistent for greater than 2 weeks, that warrants a certain different type of investigation. We usually have to go for a series of blood tests. We usually have to go for maybe an ultrasound, a CT scan, and possibly an endoscopy and a colonoscopy, depending on exactly what we're dealing with. So there are certain diseases such as abdominal tuberculosis, inflammatory bowel disease. All of these are notorious to cause diarrhea and blood in the stool. and they might even cause weight loss. And again, this is something which is more common in our part of the region, so TB is one of the things that is quite concerning. So a family history of tuberculosis or any exposure to tuberculosis might put a child at risk of developing this as well, or anybody for that matter.
Can you share some strategies for parents to maintain their children's gastrointestinal health?
If we talk about just dietary precautions, now, there are certain foods that trigger certain symptoms. Now, if you have a patient who has vomiting, usually we would prefer that patients avoid having too much tea. And this is for general population, I can't say just for children, but generally avoid having tea, coffee, or even any citrusy drinks when you're having vomiting. This actually increases the risk of nausea. If the patient is having constipation, there should be an increased vegetable intake in the diet. And at the same time, there should be reduction of too many high sugar foods or processed foods or fatty foods, right? Now, if you have a patient who's having, example, gluten sensitivity. Now, these patients specifically are quite notorious. They can't take wheat, rye, or barley. So they need to avoid taking, example, breads. They need to avoid taking biscuits. They need to avoid taking any sort of bakery items, which are, these are quite common in our food setup here. So these are the precautions that you can take care in terms of appetite to avoid if you have symptoms. And overall, our recommendation for parents usually is to make sure that the food that is being prepared in the household is a balanced diet. Again, that could be difficult for quite a few people, but a high fiber diet, not too many heavy trans fats. Basically avoid the fried food, avoid the outside food that has preservatives, the artificial coloring, the artificial flavoring. These are things that we tell them that, try to ease up on that. So obviously children will want to have these things, but maybe relying on that as a staple diet would not be such a good idea. So yeah, that's what we can advise. And as I mentioned about the water, filtered water or boil the water, these are effective measures. If you can't get the mineral water, then at least boil the water down, and then once it cools down, everybody can drink it. It's safer, it kills off most of the pathogens, and keep the surfaces clean, keep the environment as sanitized as possible. Whatever you can do in your capacity, that could help in preventative measures in most diseases.
What treatment options are available for gastrointestinal issues in children, and how effective are they?
So as I mentioned, some of the treatment options that we have, it really depends on how the child is presenting to us. Now, if I have a child that's presenting to me with severe dehydration, eyes are sunken, urine output is low, he's quite lethargic or she's quite lethargic, and the vitals are showing that there is severe dehydration, maybe the heart rate is on the higher side, the BP might be on the lower side, and the patient's just unable to consume anything orally. So I would prefer to start this patient on IV fluids. The best way to monitor adequate hydration would be to just check the urine output. Of course, this is going to be associated with checking the patient's blood tests. Is there any underlying anemia? Is there any electrolyte imbalance? Is there anything that we can correct on the spot? And then at the same time, depending on what the symptoms are, IV antibiotics need to be started, or you can even start oral antibiotics for that matter. So it really depends on what the spectrum is and how we find the patient when he first presents to us.
What are some common gastrointestinal symptoms that teenagers may experience, and when should they seek medical attention independently?
So for adolescents, the data that we have available is showing that even though they can suffer from the same diseases as children, because honestly the contamination and the overall prevalence of gastroenteritis is quite high, usually there is a huge spectrum of organic diseases that adolescents can suffer from as well. Again, celiac disease, lactose intolerance, inflammatory bowel disease, they're not off the table, they're there. But along with that, after you can rule out any organic cause, which basically means if a patient's presenting to us with chronic abdominal pain, that could be epigastric, that could be on the lower side. If they're presenting with chronic constipation, chronic diarrhea, if they're presenting with chronic vomiting or reflux disease, which is basically acidity and there's regurgitation and there's heartburn, these patients need to be investigated for organic causes. So if I talk about reflux disease, then most of the time we simply give them a proton pump inhibitor if they have symptoms like that. We see if their regurgitation and heartburn resolve from that. And at the same time, if you have a patient who's developing abdominal pain, the investigation really needs to be centered around what exactly are the associated symptoms. Are there any alarm features such as weight loss or severe anemia? Because that would warrant me to investigate something, example like celiac. I would like to do an upper GI endoscopy in that case. So we're going towards a diagnosis based on where we find that there is a pathology. So anemia is a big problem. It needs to be investigated. And of course, you're at the same time ruling out what the patient's nutritional status is, and etc. If you have a patient who has diarrhea, which is associated with weight loss, and there's also associated anemia, and there's a reduction in, most importantly, the quality of life, again, that gets investigated by certain tests. Example, we need to rule out TB, we might need to rule out inflammatory bowel disease. But then, after all organic diseases have been ruled out, or in some cases when you don't see that the manifestation of the symptoms is resulting in such a severe problem in terms of blood work or functionality, that's when you have to consider functional GI disorders. So these are basically symptoms that are quite real, but they're not backed off by any organic disease that could be found by our tests. And in our population, 10% of adolescents might be suffering from these functional disorders. So again, these need to be investigated thoroughly. Where it's warranted, it needs to be further proceed with maybe some imaging tests like CT scan, a colonoscopy, endoscopy, whatever the clinician decides. But bear in mind that functional disorders, they are a bit hard to treat. They might occur because of stress, they might occur because of anxiety. There might be different triggers for different cases, and they need to be attended with the most possible expertise and compassion there could be.
Could you provide advice for teenagers on maintaining their own gastrointestinal health, especially when making dietary choices outside of home?
So that's a pretty good question, and we're all living, we've all been young, and it's very difficult to create that discipline in life, and I think that is everybody's individual journey. As much as we'd like to put a banner that these are the rules and they should be followed, it really doesn't work like that. And it's actually the amusing part of all of this is that the generation itself kind of dictates what kind of illnesses it develops. Now right now we are seeing a huge rise in obesity. Okay, we're seeing a huge rise in fatty livers in lean patients as well. We're seeing a lot of young patients suffering from things like constipation, and we're seeing them suffering from diseases such as reflux. And a lot of this is completely correlating with their eating habits these days, with our eating habits in fact. A lot of us are reliant on processed food, on outside food, and and this is less to do with something that people do for leisure and more to do with the fact that there just isn't enough time. Now everybody works. Before, the household used to be centered around the woman, and now we're seeing that nuclear setup is sort of changing. Now everybody is working, now everybody is studying, now everybody is out of the house for a long period of time. So household food is not something which is, home-cooked food is basically considered a luxury in most setups now. So that is something we need to recognize and be compassionate about as well. Somebody did say in an interesting documentary that it could all be possible. You can have all the chocolate cake in the world, you can have all the pizza in the world, you can have all the junk food in the world, you can have the sandwiches, the burgers, whatever you want. The only condition is that in that one day, you prepare all the food yourself. If you prepare all the food yourself, you'll find that you don't need to have all the cake in the world, all the burgers in the world, or all the pizza in the world. You will actually go down to the bare minimum of what you need. Again, I would say that this is something that's a luxury for most setups, especially in our part where most people in the house are working. This is something that was inevitable, the reliance on food from outside. But the best we can do is maybe try to encourage to reduce some of that consumption and go back to having household food. Try making it yourself, try getting the produce, try preparing what you like, and hopefully that should improve. And as I mentioned that there are certain trigger foods that would worsen symptoms, but again, this would be in the wonderful scenario where people are available, people have the ability to come home, prepare the food, have all the ingredients ready. Most households over here can't actually afford the staple diets of having enough vegetables, fruits, red meat, and even poultry in their diet. So this is something that it's a bit much.
What are some common gastrointestinal symptoms that adults may experience, and when should they seek medical attention?
Now, if we move on to the adults, this is very important as well. In adults, basically, the symptoms that commonly occur, again, they're very similar. You can have reflux disease, you can have heartburn, you can have vomiting, you can have abdominal pain, you can have, weight loss, diarrhea, constipation. The alarm features from these: if a patient has excessive amount of weight loss, if the patient has anemia, which is resulting in a lot of weakness, and the anemia itself, it's a tag to low hemoglobin, but the symptoms related to it are shortness of breath, weakness, syncope, feeling pale, looking pale, having paresthesia, numbness. If you have excessive diarrhea, severe constipation, and all of these symptoms are resulting in a loss of functionality, and one of the most dangerous ones is bleeding. You could have black stools, you can have rectal bleeding, you can have vomiting with blood. These warrant immediate investigation. And the thing that in adult populations that we generally have as a top-notch priority to rule out is colorectal cancer. Now, you know that colorectal cancer is the third most common cancer in the world, and it is the second to third most leading cause of death in cancers as well. So it's very important to reduce our threshold into understanding that when a patient should be screened. Now, if you have a patient who is feeling all right, should he have a screening colonoscopy? The answer is absolutely yes. But when? So the recommendation was that it should be at the age of 50, but now we're leaning towards the bracket of age of 45, and this is for patients that have no symptoms at all. This is a screening test, which basically means you don't have to have any problems, but you should still get it done, so that, God forbid, if there's anything that gets picked up in the colonoscopy, it's at the early phase. Like, it could be a polyp, it could be a growth, but whatever it is, it needs to be assessed. And according to most studies, they have found that 50 is the perfect age in which it could be checked, but recent studies are showing that 45 is a good age to start screening colonoscopies. So what is a colonoscopy? It's an examination that's done with a camera. It examines the whole large bowel and some segment of the small bowel. And in that, we basically have the patient prepared with a clear liquid diet a day before, and the patient's given an agent that results in diarrhea to cleanse the bowel, so that the walls of the bowel can be visualized in the examination. Now, the limitation in Pakistan would simply be that how to get the information. When should the screening colonoscopy be done? What is it? Would it actually be of any use? Do the patients have to pay for it? How much would they have to pay for it? How frequently should they have to get it done? These are limitations that we have. So in some cases, patients are quite aware. They do come in, they get a screening colonoscopy. But this program somehow should be made of, as it's a screening program, to encourage people to get it done. It should either be quite cheap, or it should ideally be free, so that they get it checked. Now, in some setups, procedures can be done for free, but the awareness is not there. So the recommendation is that if you have a relative who suffers from colorectal cancer, and this is a first-degree relative, then ideally the patient himself who's coming in for a colonoscopy should get his first colonoscopy either 10 years before the age of the patient's relative who was diagnosed with colorectal cancer. So if he was diagnosed at the age of 60, you need your colonoscopy at the age of 45. Why? Because the recommendation is that get it as early as possible. So actually, it would be at the age of 40, sorry. So if your relative has it at 50, get your screening colonoscopy done at 40. If your relative has it at the age of 60, get your screening colonoscopy done at 40. So bring it down to 40. If your relative has it at the age of, God forbid, 30, you need to get it done at 20. So it's either 10 years younger than your relative, and that would be if he's younger than 40, or it should be at 40 regardless of the age.
As we wrap up your interview, do you any have final thoughts to share?
If we talk about patients that have, example, chronic epigastric pain, So they develop epigastric pain, they develop fullness, they call it bloating. They say that their appetite, they have a good appetite, but as soon as they eat, they feel full instantly. These are some of the notorious symptoms that can actually be very difficult to treat in some cases. So we ideally call this dyspepsia. Our investigation algorithm in these patients is usually that if your patient has pain and bloating and these symptoms are not going away, then first we try to find out what the patient has in terms of lifestyle. What is the food intake? Is there any specific type of food that they feel that triggers their symptoms, such as oily food? So if we find that there's a trigger food, then we try to tell them to refrain from having that. At the same time, the recommendation is to start this patient on a proton pump inhibitor. That could be a simple omeprazole. If the patient responds well to this PPI, so we would prescribe it for a total of 4 weeks, and hopefully after that the patient will need it. At the same time, we try them to avoid the trigger symptoms, possibly increase their fluid intake, try to improve their lifestyle, maybe start going on walks. So a lot of this has to do with bringing your body back into an equilibrium, bringing it back into a healthy state, and bringing up some lifestyle modifications that would increase your sense of well-being. This is not easy for everybody. There are a lot of stresses. There could be work-related stress, there could be family-related stress, it could just be stress because of the economy if you're just looking at it right now. So this is a bit notoriously difficult to treat. In the sense that the patient doesn't respond to these medications, we can do a simple test for a bug known as Helicobacter pylori. Now this is a notorious bug that is quite prevalent. I would say maybe 90% of our population probably has it. Again, this is also spread through fecal-oral route. This bug basically it resides in the stomach lining, and in some patients this bug can cause a lot of inflammation, gastritis, and eventually ulcer formation. So when patients have symptoms of epigastric fullness and bloating, these could be because of the bug. So what we do is, in this case, we test the patients for a simple stool antigen test or a urea breath test, and we don't go for an endoscopy in this case, because we usually prefer to hold off the endoscopy until it is, unless associated with some severe alarm symptoms that I had previously mentioned. Now, once you find the bug, there are multiple regimes in which you can treat them with. So we have a bunch of antibiotics that we can give in combination, quadruple therapy. We can give a combination of amoxicillin, clarithromycin, etc. There are a lot. So whatever combination suits that patient, we start the patient on those medications and see if the symptoms resolve in the next 6 to 8 weeks. So it is not such a simple process as in, if you respond to the PPI, great. If you don't, we test you for the H. pylori and we give you the medications for it and we see how you go. And then you have to give time for your stomach lining to heal. If the patient is above the age of 60, we do prefer to go for an upper GI endoscopy just to see what's going on inside, and this is generally recommended. But overall, these are just guidelines. Sometimes it depends on the clinician's own understanding. Maybe sometimes we go for an endoscopy a bit earlier. Sometimes the patient needs to be treated for H. pylori multiple times because maybe it's not responding to therapy, or the patient might have it again. Yes, that can happen as well. They does get it again if they consume contaminated food or water. So some things are a bit, they are a bit difficult. They require lifestyle modification by a huge extent, and that could be quite frustrating for the patient himself. But there are ways to deal with it.